Hi everyone, it's Dr. Hall. I'm coming to you from the school district office where I'm waiting to give some testimony. So I thought I would get this recording done for you. Notice behind me there's an AED, which is one of those automatic external defibrillators in case somebody has a heart attack and collapses, an example of public health at work to keep us healthier and safer. So now we're going to move into part 2 of communicable diseases. So in part 1, we talked about the general concepts, burden, routes of transmission, contributory causes, and then we talked a lot about potential impact, looking at the transmissibility of an infection, usually measured by the R0, and the severity, right? So mortality rate, hospitalization rates, disability, all those things. Today, we're going to talk about the tools that we have and what type of strategies we can pursue. So first, let's talk about our first tool in our toolkit for communicable diseases, which is barriers. Now, when we think of barriers, sometimes we have a very narrow concept of what that means, but for purposes of this discussion, we're talking about any intervention that decreases your risk of exposure to a certain infectious disease. So barriers, by definition, decrease your risk of exposure. It might be a physical barrier, like using condoms or wearing gloves, wearing a mask, other forms of PPE, which stands for personal protective equipment, all the way up to and including a hazmat suit. But it also includes things like bed nets, right, or screens on windows. Interestingly, I one time had a patient who was exposed to rabies because their landlord didn't have any screens on their windows. And so her window was open in the summertime because it was hot, and a bat got in and bit her, right? So there are physical barriers, and then there are environmental controls, and this just influences anything that's happening in your immediate environment. So everything from social distancing to isolation and quarantine, making sure that infected people or potentially infected people aren't in the public sphere. Also ventilation, right? How many air exchanges do we have per hour? Do we have HEPA filters? Sanitation is huge in most of the world, especially when it comes to communicable diseases. We tend to take it for granted often in the United States, but it's enormous. So you can see that image down there is of a wastewater treatment plant. Insecticides can be part of environmental controls if you're trying to keep down mosquito populations or other things like clearing brush. Hand washing can also be considered environmental control because it decreases the total number of germs that are going to be out in the environment. These things really work. So sanitation projects are incredibly important. You can imagine that if you live in a place where this is what people do with their refuse, including this is what they do with their human waste from their chamber pots, that there's going to be an incredible risk of disease in this environment, not only due to potential direct contamination of food sources or people coming into direct contact with these materials, also due to the fact that if you have a lot of refuse around, it is going to encourage populations of rats and flies and other things which can themselves transmit diseases. So one of the problems that we see in some communities is that with the lack of appropriate sanitation and sewerage systems, the number of flies is just incredible. So I had a friend who worked in the Peace Corps, and she talked about a community where she lived where the flies were just so numerous, and you can see in this image on these children's faces, right? Their faces are covered with flies. You would think, why don't you just wave those away? And my friend told me the answer is because otherwise you would be doing that all day, every moment, all of the time. That it's just impossible to keep the flies off of your face because there are too many of them. And so what we see is that, of course, these flies also transmit disease. One of your media assignments is on trachoma, which is something that is transmitted by flies, as well as some other things. Hand washing works, right? So this is looking at incidents of infections that occur in the hospital. So what they did was they implemented a hand washing campaign for their hospital staff right around here, and saw a significant decrease in 2 different types of infections that were acquired by patients during their hospital stay. And I know this seems kind of crazy that doctors maybe weren't washing their hands, but to give you a little bit of perspective, when I was in training, there were not sinks outside the patient rooms. The only place to wash your hands would be to go into the patient's bathroom and wash your hands, which was very inconvenient and also felt like an invasion of privacy, and the bathroom wasn't always particularly clean if the patient had just used it. And we didn't back then have those little hand dispensers for hand sanitizer. So during my training, actually, they started installing whole bunches of sinks in the hallways for the medical staff to use before and after they went into a patient room, as well as the little foam hand sanitation stations at the entrance to every hospital room. These things make a big difference. Notice they don't eliminate the problem, but they make a big difference. Masks also work, as does eye protection, as does physical distancing. So this is looking specifically at COVID infections. So depending on the type of infection, different types of barriers are going to be effective depending on its route of transmission, right? So COVID-19 is airborne transmission. So we know distancing, masks, and eye protection work. Again, I'm going to point out it's not 100%. Rarely anything is, right? But so you can see that the incidence of infection in their staff in this study that weren't wearing masks was 17%, and of those who were wearing masks, it was 3%, right? So it was 5 times lower, right? It was 1/5 as high. Significant impact. So again, nothing is perfect, and that's why we need to be clear that wearing a mask helps a great deal, but it is not a 100% preventative. And that's why we recommend layering strategies. So you may have heard people talking about layering mitigation. This is why no one thing is going to work. So every potential intervention has holes, right? Some virus is going to get through. But so we have this kind of Swiss cheese model where if we layer all these different things together, the likelihood that the virus is going to be able to get through all of them, despite the fact that each of them have holes in them, is much lower. So that's why it's so important to layer mitigation strategies, use multiple interventions in order to significantly decrease disease. All right, let's talk a little bit about immunizations and how they can help us control communicable diseases. So first, a little quick primer on how immunizations work. So what happens is you purposefully expose someone to either a weakened version of a germ or a piece of a germ. And there's lots of different ways that you can do that. And one of the things that's new about the COVID-19 vaccines, relatively new, is the way in which we do that, right? But still, the ultimate thing is you're going to expose somebody to a piece of a germ so that the immune system then, in step 2, learns how to recognize it and learns how to fight it. So our immune systems are really amazing, but it takes them time. So it usually takes them 5 to 10 days to start developing antibodies against any one particular germ. And it can take them even longer to develop some of the more nuanced tools that they have to fight infections, like T-cell responses. So we want to give them a head start, some advanced training and preparedness, so that then in step 3, if you get exposed to the germ, your immune system is already primed and ready to go. Sometimes vaccinations or immunizations can be so successful that your body is able to completely prevent you from even getting infected at all. Sometimes it's not that strong, but vaccination and immunization can still make a difference in your outcomes. So there are 3 different potential goals of immunization or vaccination, and I'm going to use those words interchangeably. One, it would be great if we could prevent infections entirely. And in the early days of the COVID-19 vaccines, it looked like we really could do that. Those were the good old days, right? You also want to be able to prevent or decrease transmission. Again, early on, the vaccines for COVID-19 showed promise at doing that. Now, with the evolution of variants and waning immunity over time, that seems to be less effective. Not zero effective, but less effective. We really, really want to prevent bad outcomes. So this is where the money is, right? We want to prevent suffering. We want to prevent severe illness. We want to prevent premature death. So the gold standard for how well your vaccination is working, is it keeping you alive, right? Is it preventing you from having severely severely bad outcomes. And fortunately, in the example of the COVID-19 vaccines, they are still doing that. Doesn't mean nobody who's fully vaccinated and boosted ever dies, but they are statistically much less likely to. I think it's important to recognize that in the United States, we've been a little bit spoiled by our history of success when it comes to vaccination campaigns. So this is a listing of vaccine preventable diseases and the percent reduction in both cases and deaths that we have seen since introducing the vaccine. So you can see diphtheria is gone, right? 100% reduction in cases and deaths. Measles, nobody dies from it anymore, and almost nobody ever gets it anymore. It's practically unheard of. It makes national news if there is a measles case. Mumps, again, nobody dies from it anymore, hardly anybody ever gets it. And if you look at pertussis, you can say, oh, it's not quite as good. We'll talk about that in a second. But look, polio, gone. Rubella, which is German measles, practically gone. This is what measles looks like over time, and you can again see the dramatic improvements that vaccination have brought. They are one of the most remarkable tools we have for improving the health of a population. I'm continuing on down that table because I want to show you a few other things, right? So smallpox completely eradicated from the world thanks to vaccination. Tetanus, significant decrease, almost completely eliminated. Hepatitis A, we still see that from time to time. Hepatitis B, we also still see from time to time, but vastly reduced. Pneumococcal disease, that's been a little bit less successful, but still to reduce deaths by 30%, that's really significant. And then varicella, which is chickenpox, is the last one. So one of our goals here is to get herd immunity. So as we see, if nobody's vaccinated, a disease can spread rapidly through a population. If some people get vaccinated, it happens a little bit more slowly, but it's still going to infect a lot of people. What you need is for most people to get vaccinated. Once most people get vaccinated, then the disease can't spread. And that is herd immunity. And so we've reached herd immunity for a lot of illnesses in the United States, which is why we practically never, ever, ever, ever see them. Or if they do, like for example in measles, it's usually someone from another country who comes into the United States. And once they get here, they often don't spread at all because we have herd immunity. Because most people are vaccinated, right? And so it just can't spread. Okay. So what's really important to know is that to get to that point of herd immunity, you have to have really high levels of vaccination. Anything below that level will not result in appreciable differences in community transmission. You'll be like, oh, look, 60% of people are vaccinated in this country versus that country, and they have just as many cases of COVID-19, for example. Yeah, that's going to happen, right? It takes a really high level of immunity to prevent transmission at the population level. Those vaccinations are still helping at the individual level. They're just not enough to make a difference at the population level. So the metaphor I like to use is the question is, how many holes are in your boat? So if I'm in a boat or a raft and there's a few little tiny holes, it's not going to be a big problem, right? So, if some water is going to seep in, I'll be able to bail it out. I'll be able to take care of it. But if I have lots of little tiny holes all over the boat, I'm not going to be able to keep up, right? So you really need to have not a lot of holes, not a lot of non-immune people, not a lot of unvaccinated people. So how high does that level of community immunity need to be? Well, what's interesting is you can actually use that R0 number to figure it out. So there's a calculation, there's an equation in the book. I won't make you learn it, right? But depending on what the R0 is, you can calculate about what percentage of the population needs to be effectively immune in order to reach that herd immunity. So you can see for measles, for example, down at the bottom, which has that really high R0, you need somewhere between, 80s to 90% of the population to be effectively immune. And it turns out that in the United States, 91% of 2-year-olds have been fully vaccinated against measles. And that's why we hardly ever see measles, right? Because also that vaccine is nearly 100% effective. So it's amazing, it's incredible. Now, pertussis, you notice pertussis also has a really high R naught, and the threshold is also similarly high. And in our country, we only have about 81% vaccination rates against pertussis. And so we do see pertussis. It crops up frequently in our local county health departments, and we have outbreaks. I've had pertussis, which is whooping cough. Perhaps you have too. So depending on how contagious something is, that tells you what percentage of the population needs to be effectively immune in order to reach herd immunity. So because no vaccine is 100% effective, you need to factor that in. Okay, so if we use diphtheria, for example, you need an 85% effective immunity level. So that means if the vaccine is 85% effective, I need 100% of people in the community to be vaccinated, right? Whereas if the vaccine is 100% effective, I only need 85% of the population to have received it. So you have to factor that in as well. So early on in COVID, when it looked like the R naught was about 2 to 3, they were estimating perhaps we needed 60 to 70% immunity at the population level. And of course, over time, as the virus has evolved and mutated, and now we have variants with higher R naughts, that number keeps going up. It's not because they got it wrong the first time, it's because the situation is changing. While we're on the topic of vaccines, it's also important to talk about disparities. So vaccine equity is a big issue globally, and the unequal distribution of vaccines is a big problem, especially when we're fighting a global pandemic. So what you can see in this graph here is along the bottom, you can see, sorry, I'm balancing some of that. You can see gross domestic product, right? So the wealth of the nation. So our wealthier nations are over here. And in general, right, you can see this relationship that the wealthier nations have more of their population vaccinated against COVID-19 in this specific example. Now, notice that there is a lot of individual variation even within certain economic groups, right? So Russia and China, right? Significant difference there, despite the fact that they're as wealthy as each other. So it's not just about money, although a lot of it is about money. But it's important to recognize there are a lot of other factors that impact how effectively you're going to be able to vaccinate a population. So funding is one of them. But supply and logistics is also another one. So for example, one of the challenges with some of the lesser developed nations has been we could ship them thousands of vaccines, but they may not have the freezers or the refrigerators in order to store them properly. They may also not have staff who are trained to give them. They may not have systems for tracking them and doing the administrative piece. Right? So there are all these other things involved besides just having the vaccines themselves. Another factor that I think we've all experienced is really important is the role of communication and trust. So in the country of South Africa, for example, they had plenty of vaccines. But before Omicron, hardly anyone was getting them. It is a country where there is a long history of mistrust of the government and mistrust of authority. They couldn't give them away. That sounds a little bit familiar, right? So here in the United States, where there are currently very high levels of distrust in our society, it is very hard to get people to trust the vaccine. And so we see very low uptake of the vaccine for that reason. That's one of the reasons why we see the difference between Russia and China, for example, is that level of mistrust and lack of communication. Of course, in terms of federal, state, and local rules, that's where things like vaccine mandates and requirements and incentive programs, as well as education and communication programs, come in. So vaccine disparity is a significant issue. We are making progress, though, globally when you look at all vaccine preventable illnesses. So this is relatively a short period of time, according to someone who's lived as long as myself. So from 1990 to 2017 here, we're looking at numbers of child deaths. Okay, so these are numbers of children who die globally. And everything that's in the colored parts are vaccine preventable or potentially vaccine preventable illnesses. And so what's really lovely is that although certainly we've seen a decrease in other causes of death, the gray bars, we have seen a profound decrease in, look at the size of this, right? Now to the size of this. So vaccination campaigns globally around the world, especially for children, have made huge improvements in childhood mortality. This is a huge success story. So our next tool is going to be screening and case finding. So identifying people who have the disease or the illness. So who has it? So screening, you've already learned a lot about screening from Unit 6, right? So again, if we're going to do a screening intervention, we want to make sure it meets all the same criteria, which in brief are that the condition is relatively prevalent, right? It's not a needle in a haystack, and that it's something that is asymptomatic, that you have to go looking for. We also want to make sure our test is good, that it's going to give us accuracy, that our positive predictive value and negative predictive values are going to be high, and that the test itself is not going to be associated with potential harms. And then we want to be able to do something once we have that result. Now, in the case of COVID-19, we don't have a lot of effective treatments available to us. So what we end up doing once we have that result is we end up isolating and quarantining folks, right? Because that's one of the only tools that we have. Case finding is slightly different then. So this is related to the contact tracing that perhaps some of you have had experience with over the course of this pandemic. So this is the public health approach to then finding other infected people. So you're going to talk to the person who's infected and then identify their potential close contacts to see who might be at risk. They're going to do their best to maintain confidentiality and privacy. So they're not going to call up your ex-boyfriend Joe that you broke up with 2 weeks ago and say, hey, we think Caitlin gave you chlamydia. They're not going to do that. They're going to say, we have reason to believe that you've been exposed to chlamydia sometime in the past month, right? So they'll give general information so that the person can understand that they're at risk, but they're going to work really, really hard to protect privacy and confidentiality. And then this allows for notifying those people who are at risk of having been infected so that they can get tested, they can quarantine if necessary, they can get treatment, right? So that's the case finding, right? Finding the other people to whom you may have spread it. Once we identify cases, whether through screening tests or through contact tracing, we're going to look at treatment. We're going to treat the cases not only to treat their illness, right, of course, from a medical standpoint, but also from a public health standpoint. Oftentimes treatment will decrease or eliminate your ability to transmit it to others, right? So you're no longer going to be infectious. That works for some types of infections and not others. As I mentioned, for COVID-19, we don't have a treatment that makes you no longer contagious. That doesn't exist because it's a viral infection and they're tougher that way. So sometimes it helps that way, sometimes it doesn't. Treatment then of contacts. So interestingly, if, for example, someone has been exposed, sometimes we'll just treat them right away without even waiting for a test result if we think the probability that they're infected is very high, or if there's a need to act right away. In the case of meningitis, for example, which can be rapidly fatal, public health officials will identify all potential contacts and treat them all immediately with antibiotics. We don't have time in that circumstance to test people or monitor them and see if they develop symptoms, because sometimes by the time they've developed symptoms, it's too late and you could have a fatal outcome. So we will often empirically or presumptively treat contacts without checking first to see for sure if they have the infection. Now, of course, we have to weigh risks and benefits with that. There are risks associated with the antibiotic and other treatments, but in the case of it potentially saving your life in a meningitis outbreak, for example, it's felt to be worth it. We had a meningitis outbreak on a campus I worked at previously, and within 24 hours, we treated 400 people with antibiotics, right? But it worked. Nobody else got sick. But sometimes these things can be really quick and urgent. So let's use the example of chlamydia. So we do screen for chlamydia because it meets our criteria. In female-bodied people who are 25 and under and sexually active, there's a really high prevalence in that age group, so it's common. It also often has no symptoms, so it's asymptomatic. We need to go looking for it, and it can cause serious problems in terms of infecting their uterus and fallopian tubes and causing future infertility. And our test for chlamydia is excellent. Sensitivity and specificity are over 99%. It's really good. When it comes to men, interestingly, or male-bodied people, many of the same factors still apply, but they're not as at risk for serious outcomes themselves. Now, of course, they're transmitting it to other people, but they're not at a high risk of a serious outcome. So when it comes to whether or not to screen men, what we do is we look at the prevalence within that population. On our college campus, chlamydia is fairly prevalent, so we do routinely screen male-bodied people. Right? In other places where it's less prevalent, it would make sense to say, well, no, it's probably not worth it in this case. So we do screening, and that allows us to identify cases, right? So then we're going to try to find if there's additional cases associated with that infected person. So we're going to ask people who are diagnosed with chlamydia to notify their sexual partners, or if they don't feel comfortable doing it or they're embarrassed to do it, we can get public health staff involved and they can notify partners in that anonymous, confidential way. So not everybody feels comfortable saying, hey, guess what, Joe, I think either I gave you chlamydia or maybe you gave me chlamydia. Not everybody wants to have to make those calls. So the public health department will help and they'll do it for you because the goal is to prevent illness, right? So of course, when someone's diagnosed with chlamydia, we're going to treat them with antibiotics. The nice thing about chlamydia is you can cure it, which is great. And after 7 days, they are no longer infectious to others. Super important that they don't have sex at all during those 7 days. We want to make sure they're totally done with their infectious period. And then once we've identified their sexual partners at risk of having been infected, we're gonna, when they come into the clinic, we'll test and treat them the same day without waiting for results. Because we don't want to take the chance that while we're waiting for that test result to come back, and then the person's no longer in the clinic, and then maybe we call in a prescription for them, but it's a hassle and they don't go to the drugstore. And so what we've found through data over the years is that the most effective intervention is to treat them right that day. Do some people end up getting unnecessarily treated? Yes, but in the risk-benefit calculation, it's way worth it because with the other strategy of waiting for test results, too many people go untreated and go on to transmit it to others. One thing we can also do if someone can't come in to get evaluated is we'll give a prescription to them directly. So sometimes we'll call it into a pharmacy for them. We'll just have a conversation on the phone. This is called expedited partner therapy, and it's another way that we can try to halt that communicable disease in its tracks. So those are our tools. Barriers, which is a huge category composed of everything from personal protective equipment to environmental controls to hand washing, right? Lots of things. The role of immunization, very powerful tool, screening and case finding, and then treatment and contact treatment. So now we're going to talk briefly about strategies. So basically, when it comes to communicable or infectious diseases, we have two potential goals. One is to eliminate the disease, and the other is to control it and therefore limit the suffering that it causes. So can we eliminate the disease? The book does a really nice job talking about this. It's going to depend on all of these factors listed because they're going to impact whether this is a realistically achievable goal or not. So one question, is there an animal reservoir? In the case of smallpox, for example, which we have successfully eradicated, that requires person-to-person transmission. There's no intermediate host of a mosquito or a tick, so it was easier to control. In the case of COVID-19, there are lots of animals that seem to be able to get infected with it. We're not totally sure if those animals can then give it back to humans, so that question is still open. The next factor is it short-lived in the environment? So some germs are relatively wimpy, right? If you cough out, a certain virus and it sits on a tabletop for a few hours, some of them will just shrivel up and die. Some of them, however, can remain active for days. So that's going to make it harder to control and harder to eliminate. In terms of COVID-19, we think it can persist in the environment for several hours, potentially several days. That's not the worst thing in the world, but it's not awesome either. Are there any long-term carriers or not? So it can be really challenging that in some diseases and infections, there are people who've had the infection in whom the germ continues to live, even though they don't have any symptoms, even though they're no longer sick, and though they can spread that germ to other people. This is the case with mono, or infectious mononucleosis, caused by the Epstein-Barr virus, also called the kissing disease sometimes. So some people who've had mono before, about 10% on average, continue to carry the virus in their throat all the time at varying levels, and then they can give it to other people, which is why a lot of the times when somebody comes down with mono and we say, well, have you been around anybody else who's been sick with it? They say, no. Right? And they have no idea where they got it from because they got it from one of these asymptomatic long-term carriers. Does this happen with COVID-19? Not usually. We do see some people with chronic long-term infections if they have a suppressed immune system. So it's something to keep an eye on. The next criteria, is herd immunity possible? Right? So in order for herd immunity to be possible, your R0 can't be crazy high, and or you need to have a vaccine that's highly effective and that the population is willing to get, right? You have to be able to achieve high levels of community immunity, right? And if you can't do that, then herd immunity is not going to be possible. The next category is their long-lasting immunity, whether from natural infection or vaccination, does the immunity that you get last a really long time? So for example, with measles, yes, absolutely. So we've practically eliminated measles from the United States because the vaccine-induced immunity lasts pretty much your whole life long. It's amazing, actually. Now, what about COVID? Well, the immunity from both natural infection and the vaccine wanes over time. So what we see is that, oh gosh, it's looking like we're not going to be able to knock this out of the park. It's probably going to be more like influenza, because with influenza, we also don't developing long-lasting immunity. It is one of several reasons why we need to get shots every year. Next criteria, is it easy to diagnose or identify, right? So that then you can rapidly isolate, treat, contact trace, do all those things. With smallpox, it sure was. You had this crazy rash on your body. COVID is tougher, right? Because a lot of people have no symptoms whatsoever. There are no physical signs that are classic and diagnostic. You need to do tests, which is possible, but not the easiest thing in the world. And then the last criterion is, are there post-exposure vaccinations that work or post-exposure treatment that works? So a cool thing about smallpox is if I'd been exposed to smallpox and then you gave me the vaccine, that could prevent me from getting smallpox. That almost never happens. Usually your immune system needs that advanced warning system from a vaccine ahead of being exposed for it to work. But in the case of smallpox, it did work. If you have post-exposure treatments that are highly effective, say you could give me a medication once you diagnosed me with something that would effectively treat it so that I can't transmit it to others, that would help. We don't have any of those things for COVID. So what's going to happen with COVID, right? So over time, eventually, COVID is never going to go away entirely. We're never going to be able to eliminate it. Initially, we thought we might, and not without good reason. So the predecessors, the other viruses in the same family as SARS-CoV-2, SARS-1, and MERS, which is the Mideast Respiratory Syndrome, we were able to totally clamp those down. Now, in large part, that's because their R naughts were really low, 0.6. So on average, one person infected less than one other person. So they were much easier to control. So we were optimistic. And COVID is not cooperating. So what will happen over time is that we're just going to have to live with COVID. But as more and more people develop immunity, either through vaccination or natural infection, then the severity and the frequency of outbreaks will eventually lessen. They will still regularly occur, however, right? But the frequency and severity is going to depend then on how much the virus mutates and how many variants we get and what the characteristics of those variants are. Omicron right now is changing the game yet again. And our ability to develop highly effective immunity at the individual level, like how well does the vaccine work in me, or prior infection, how well does that protect me, but then also at the population levels. So we are going to continue being in a pandemic instead of an endemic until we have very high levels of community immunity, either from vaccination or natural infection. And depending on how long lasting and effective that immunity is, that's going to determine for how long is this virus going to really dominate our lives versus at what point is it going to become, for example, like flu, something that still happens, something that can still make you sick, something that still causes tens of thousands of deaths a year, but not something that causes hundreds of thousands or millions of deaths per year. So that's where we're headed eventually. When will we get there? Well, gosh, I wish I knew the answer to that question, right? Eventually. It might take some time. Okay, so we have now talked about both the tools for addressing communicable diseases and the potential strategies. So right now with COVID, of course, we are in the control strategy where we want to limit the severity of the illness. We want to avoid overwhelming our hospitals so that we preserve that resource so that no one dies due to lack of appropriate hospital care, right? That would be a potentially preventable death. All right, everyone, that's it for Unit 7.